It was a very detailed review on syncope, sir. And what is your experience on the nocturnal syncope? Many times we see elderly individual when they go for urination, they have a syncope. So I feel that is the one which is very commonly I see in my clinical practice, apart from the arrhythmias. And the second type of syncope we see in acute blood loss, some GA malignancy or some bleeding melena, and they have a syncope and they recover when we see the patient anemic hemoglobin 8. So these two kind of syncope should not be missed apart from the pulmonary embolism one.
Yes, you are correct. The thing is that elderly syncope, it admit and evaluate, because you don't know what you are dealing with. It could be a dangerous thing, most likely a dangerous thing, and less likely a non-dangerous thing. And then the commonest etiology in elderly people are orthostatic hypotension, unless proved otherwise. The etiology could be drugs, most common nowadays, because our target BPs are going down, down and down. So it's most likely uh, hypotension due to drugs, but precipitated by an intercurrent illness like an upper respiratory infection, or they might have skipped a meal, they forgot to drink water. That could be very simple things, but it has to prompt us further evaluation in elderly. The GI loss anemia related syncope, yes, clinical thorough examination is a must, because those are dangerous subset. Without intervention, you risk losing the patient's life. So we have to be, all out, both eyes and ears, for any clues to the diagnosis.
So I want your comment regarding the head up tilt test, HUD test. Should we be still doing that as a part of evaluation? I want your opinion and also Dr. Nambudri sir's opinion on the head up tilt test.
We are still doing, in our center, we are still doing head up tilt tests, basically because it is not, I won't say it will add anything, rather than telling the patient that, look, I know what you are having, just to reassure the patient that that you are dealing with such and such disease, and then you need not worry. So for these two reasons, you have to bring back the same symptoms which the patient had during the testing, and then tell the patient, look, this is what you have, and this is what your treatment is like. You take a lot of water, you increase your salt intake, you do the isometric exercises regularly, and then you do the exercises, which the leaning exercises, then you will become normal, just for reassurance, because as a treatment you're not going to offer anything. So you have to tell them, look, yes, I know what you're having, I'm confident that this is it, prove that this is it, and then tell them that treatment, and they will accept it. For that reason, I'm still doing it. Sir?
I fully agree. Actually, that is the point. It is quite reassuring. Probably you may not have a tilt positive test every time if the history is classical, even if the history is classical. But it is quite reassuring, and if it also helps to categorize the type of response. And in some middle-aged and all, if we consider a pacemaker and all, it's extreme case we consider a pacemaker for a malignant syncope related to neurocardiogenic syncope. So still it is in that case also it helps. Generally we avoid doing tilt test at the in the elderly, because if there is a problem related to isoprenaline or a transient syncope, hypotension and all, we generally avoid after the age of 65 to 70 years. Routinely we usually do it in neurocardiogenic syncope, especially if there is there is a confusion regarding seizure versus syncope, because in our hospital we have a very dominant neurology wing also. We get a lot of patients with syncope versus seizure in young age. There also, if we have a positive test, it generally helps.
It is typically you make a diagnosis of vasovagal syncope, and then do the tilt table to confirm it. When you are in doubt, then it is better not, and take precautions at this age. History is more important, and then syncope, it is not an individual uh, treatment. It should be a team. The team should contain a neurologist, a cardiologist who is interested in the syncope, and then a team of people who can do the tilt test for you, can interpret your ECGs and all, looking at your long loop recorders and all. So you need a team to do it. So if that is there, then it becomes easy for all of us.
Thank you, sir. Thank you for the wonderful presentation. Let's move on to the next topic. Let me invite Dr. Sivarakasan sir again for felicitating Dr. Nithiyan. So let me invite Dr. Ajit Tachal, the senior interventional electrophysiologist from Lisi Hospital, Cochin, for this next talk on emergency management of cardiac arrhythmias.